hold the heel, put a little bit of internal rotation on the foot, and what that does is when you rotate the foot in, then you're bringing this side or the lateral side of the tibial plateau up and catching the meniscus. So everybody understand that? Rotate in, this tibial plateau comes up, catches the meniscus. Okay, and then you're just coming down and you're looking for any popping, clicking, catching, pain. Is that good? Pain there? Okay, now you're going to do the same thing on the outside. So, external rotation, fingers in the joint line. That's like more in your patella though. That's your patella, I feel it. So that's why it's important to have your fingers in the joint line. So his patella just popped. Like right on my hand, but nothing in the joint space. Okay. All right, so that's
So what makes it positive?
McMurray's popping, clicking, catching. Right. Okay, so for our Lockman test, you want to have to do this at 30 degrees. 30 degrees, okay? When you do a Lockman, it's not at 90, it's at 30. I'll say that, and then somebody's still going to do it at 90, right? It's not an anterior drawer, it's a Lockman. So, knee underneath. Relax here. Okay, this hand is going to hold down the femur. This hand is going to go underneath the gastroc, okay? And what I'm trying to do is, I'm trying to pull the tibia up and out, up and away, right? To see if the ACL is still there, basically, right? So, it's tight, it's firm. So, what will make this test positive is anterior translation of the tibia with no firm endpoint. Okay, so if you don't know, because we didn't go over it yet. It's going to be, I think, probably tomorrow. We'll get into that. But if the tibia slides forward, slides this way, and you don't feel a tight, firm endpoint, then that's a positive test. Okay, it's indicative of a torn or ruptured ACL. All right. Okay. We don't really, you notice it's probably not, it's not on your PCL, the anterior drawer test. We covered it in a lecture, but we don't do it in the PCL because of false negatives for ACL rupture. So this one's the posterior drawer. Sit on the foot, fingers in the joint line, and then you're just going to push back. So you're pushing back on the head of the tibia, and you're looking for posterior translation of the tibia. It would be indicative of a ruptured PCL. You're going to flex the hip and then the knee at 90. And then take a look at the underside of the tibia. Looking for the tibia here. If the PCL was gone, the tibia would be kind of sagging down. And you would see a sulcus right here. I don't see that. If you did see the sulcus, to confirm the sulcus, you're going to have the patient to kick. I need you to kick your leg up like that towards the ceiling. Okay? And then if you instruct them to kick the leg up, and then they're going to try to kick the leg up, go. And so if it was positive, and he had that sulcus, and he had a torn PCL, when he tried to kick like that, you would see the tibia pop back up into place. Okay? So that's for a ruptured PCL. Overs, go ahead and line on your left side. Good. Okay. Under, grab the leg, support the hip always, relax. Good. Okay, so you get the weight of the patient's leg, So you're gonna AB duct, and then you're gonna extend the hip, and you're looking for the leg to be able to come down to the height of the table. This is looking like it's gonna be positive. Yeah, you're tight, man. This is for ITB tightness. I can feel it. Like, put your finger on it. It's like
no homo.
it's like this.
Sounds like he does a lot of running, like up hills and trails and stuff.
Is that what you do? You need to stretch more, dude. Alright, so over test. So what will make it positive is if when you raise the leg and you bring it back and lower it, it should be able to lower it to the level of the table. Alright? Special test. Feet, take your shoes off.
Inspection, toe alignment, bony prominence, pes cavatus, pes plantus, pes pars, pes valgus, skin subcutaneous tissue, and surrounding musculature.
Okay. Pes cavus, pes planus. Stand up. Step forward a little. Okay, good. Toe alignment looks good. Looks like he has a normal arch. So, pes varus and valgum. That's from the back. Which way would be valgum? If I'm looking from the back like this. Alright, so if you notice that his medial malleolus is coming in, right, then that's going to be valgus. And the other way would be varus,
Sure.
right?
Yes.
Skin, subcutaneous tissues, same thing we're looking for always. What else?
Surrounding musculature and the toes and bones.
Yeah, pes cavus and planus. So pes cavus would be if he had a really high arch, right? High arch. Pes planus would be a somebody flat foot. So I took my shoes off. Pes planus. He's got a normal arch though. What else?
Red toes. Red toes.
What?
We got just red toes.
Yeah.
We keep saying whip toes over and over again.
Like what he
What
has.
about it? Oh, you just wanted to find an intro to throw him under the bus? Okay. Alright, cool.
It's not a joke though, he has red feet.
Okay, good.
That fat fuck over there.
Alright, so
He kept saying whip feet.
medial malleolus, lateral malleolus, the base of the fifth, metatarsal. What else?
Calcaneal tuberosity.
Calcaneal tuberosity. So that's the insertion of the Achilles back here. Right?
Navicular.
Navicular.
Erroneous longus brevis.
Erroneous longus brevis starts at the fibula and then tracks down the side of the leg. ATFL, anterior talofibular ligament, it's right here. The calcaneal fibular ligament, that's back here. And then the PTFL, posterior talofibular ligament, it's in the back right here. So the ligament that attaches the talus and the fibula. Alright, so ATFL is the one that's more anterior, CFL is more lateral, and then posterior is posterior. Okay?
Anterior tibialis.
Anterior tibialis, right here.
Range of motion, active and passive. Ankle dorsiflexion, ankle plantar flexion, subtalar inversion, subtalar eversion, toe flexion, toe extension.
Okay, dorsiflexion, so raise up. Okay, plantar flexion. You're good. So inversion, so the bottom of your foot in. Eversion. Good. Okay, toes up. So just your toes. Just the toes. Good. Now flex the toes. Okay, good. What else was I missing?
You hit 'em
That's
all.
it, right?
Yep.
Okay, good.
Strength, same deal.
Okay, so dorsiflexion, so go ahead and raise up against my hand. Good. Okay, step on the gas. Good. Okay, I want you to try to rotate your foot in, okay? Go ahead, rotate your foot in. Good. Okay, I want you to try to rotate your foot out. Okay, go ahead, rotate your foot out. I'm not doing anything. I'm not even putting resistance. Do it again. Just do it regular. Okay, good. All right. Okay, good. So just resistance against those two movements, inversion and eversion. Okay. Second guess. Okay, good. So now I'm gonna try to pull your toes up. Don't let me. Okay. Okay, good. Now push your toes up against my hand. Good. All right. 5 out of 5. Do that on both sides.
Special test, anterior drawers.
Okay, so just like for the knee, we have an anterior drawers. For the ankle, we have an anterior drawers. I'm going to switch positions just so they can see here on this side. So grab the calcaneus. You're going to put pressure against the front of the tibia, and you're going to pull forward. So I'm doing this. Okay, just like that. So this is assessed for the a torn ATFL. Okay, good. Same thing that makes the knee positive is what makes this positive. No endpoint. You go back over there if you want. Okay. Same deal. I'm pulling. I'm looking for a firm endpoint here. Okay, inversion stress, right? I'm gonna take the foot and I'm going to evert the heel, and this assesses the CFL. Okay, calcaneofibular ligament.
Man, fitness studio.
So I'm looking for a firm endpoint. Okay. CFL. Okay.
Thompson's.
Okay, I'm gonna do the high. I'm gonna do the squeeze, right? Typic squeeze. All right, so typic squeeze. I'm just gonna. I'm looking. So here's the head of the fibula right here. Tibia is right here. You have the membrane, interosseous membrane. I'm just gonna grab the fibula and the tibia, and I'm gonna try to squeeze them together. Okay. If that causes pain, that'll be indicative of syndesmosis or hot ankle sprain. And then if you could, just turn over and line your belly for me, please. Okay, now I'm going to look for the Thompson test for Achilles rupture. So when I squeeze the calf, you should see the foot dorsiflex. Okay, so that's negative. If you squeeze the calf and the foot just stays, then it's indicative of an Achilles tendon rupture.
After that, limb measurement, measure leg length, and then measure thigh and calf circumference, figure of 8 for ankle effusion.
Okay, I don't have a tape on me. Does anybody have a tape? Soft tape?
Do you actually need to get one for the PCL?
Catch.
Yeah. No,
You gotta go on there and measure? No.
Alright, so just find the ASIS on the patient. ASIS, it's right here. Start there. Level of the ASIS into the medial malleolus. 35. Same thing on this side. ASIS to the medial malleolus, that's 35. Okay, so you got equal length of the leg. So the thigh, you're just gonna find the center of the quad, measure around, and then the center of the quad, measure around, right, for atrophy. Center of the calf, same thing, measure around the center, and then measure around the widest portion. And then for the figure of 8, start at the medial malleolus, go around, and then whatever your number is should be the same on this side. That's to measure for edema. Okay. All right. So ASIS to medial malleolus for leg length. The center or the largest portion of the thigh, and the same thing for the calf. And then figure of 8 from the medial malleolus around the underside of the foot, inside around the lateral portion. And then whatever number you get should match on this side. Okay? That's it.
That's it.
Thank you.
And cut.
All right.